Welcome all. Thank you so much for being here tonight for COVID-19, what we know and what's next, an IDF virtual education event. My name is Ashley Ferreira. I work with the Immune Deficiency Foundation, and I will be your host for tonight. So with that, I would like to hand it over to our president and CEO of IDF, John Boyle.
Hello. It's lovely to see everyone here this evening. And on behalf of the Immune Deficiency Foundation, I would like to thank you for joining us for this virtual education event. We know that it's been a real journey and a trial for many over these last weeks and now months. And so it's really why we're grateful to have our presenters, our exhibitors, and especially you here today. And in terms of you, we know that a few of you are return attendees, so welcome back. It is always wonderful to see you. I'm glad that you were so interested in what you heard the one time you came back for a second or third or fourth helping. But what I really want to do is welcome all of our new participants. The fact that you found us here is great. We hope that this will be of use to you, and we just hope that you'll enjoy it, because our events, in person as they were and now virtual as they are now, are really meant to foster a community here that we see as empowered by education, is what we like to see. And so some of the words that you see there on your screen are among our values, our guiding principles, and constituent promise that really guides not only this program, but really all the programs that we have. So those are words that are they have a lot of meaning to us, and that really help to make sure that we are doing what it is that you ask of us, because the reason we exist is because we exist to serve you. We're committed to you, our community, to serve as a resource. Let's say a trusted resource, since it can be a little bit difficult to figure out what's what and what's accurate these days, and really to use the tools at our disposal, technology, and of course the great Zoom platform, to just make sure that we continue to have a community, one that is built on compassion and acknowledgement of the tough times, as many of us are going through. And we just appreciate your being here together with all of us. So we are all here together in part because of the support of some of our sponsors. And so I'd like to take a quick moment to thank the sponsors of our event. This includes our core service leaders, CSL Behring, Grifols, and Takeda, our core service sustainer, Horizon Therapeutics, our national sustainer, Accredo, and our national patrons, Diplomat Specialty Infusion, Kedrion Biopharma, CVS Specialty, Quorum CVS Specialty Infusion Services, Koru Medical Systems, and Kava Fusion. Once this meeting is over, and it will eventually be over, and you'll go on to your families and dinner and all that good stuff, the fun and the learning does not have to stop. So we really hope that you will, especially if you're newer to us, please go to our website. There's a lot of information about COVID. Obviously, that whole page dedicated to that, but publications, online support groups, updates about upcoming events such as this and other ones, help with insurance, other issues that you've got. There's just tons in there that will allow you to connect, as well as, of course, social media, where sometimes you get the emails, sometimes you don't. But if you're following us on all of our social media channels and you're interacting with us and letting us know about things, as people certainly do with me pretty regularly, it's just a way for us to have two-way communication, which is really what we want. So with all that said, let me just thank you for being a part of our community, for showing up. Hopefully you will learn something tonight, and hopefully you will pass that information on to other zebras in your life. And your participation allows us to figure out what it is that we can and we should be doing next, because we want to do all that we can as we all adjust to this new normal. So with all that, I'm done with my little monologuing here, and now I would like to pass it over to and invite our friend Sean McCabe from Takeda for a quick word from one of our sponsors. Sean?
Thank you, John. I think I'm on mute. Can you hear me? Great, thank you. So just a sincere thank you first to the IDF. We've attended, I think, every one of these and have found an incredible utility on just the ability to listen and understand the needs of the community. So thank you to the IDF for adapting to the needs of the group in such a great fashion. And then obviously to the HCP president, I apologize, I mispronounced the name, either Dr. Joshi or Yoshi. Thank you for serving the community and the front lines during these incredibly challenging times. You're all true heroes in the HCP community, and our sincere thanks on behalf not only of the organization, but the community of patients and everyone you serve. So just a very brief background of Takeda. If you're not aware of it, we've had a pretty remarkable journey as of late, starting at Baxter, became Baxalta, Shire, into Takeda. And if you don't recognize the manufacturer, we are the proud manufacturers of GammaGuard, Cuvitru, and HyQvia. But we're not here tonight to talk about our brands. We're here to listen and understand your needs. So looking forward to that opportunity in the breakout, where I'll be joined with Dana Flathammer, who's the head of our community support team. And just a little bit of a shout out, I guess, to the industry as a whole. I know our industry peer in CSL is also present. Very proud of the alliance that's been formed across plasma manufacturers to try and develop a solution to those in need right now afflicted with COVID with what's called a hyperimmune. So incredibly proud of the efforts of pan industry. That's when those competitive dynamics break down and the focus on the humanitarian effort takes precedence. So really proud to be a part of all this. And thank you very much.
Thank you so much, Sean. We appreciate your words, and thank you, John, for your welcome. So before we begin with our presentation, I did want to give a quick disclaimer. IDF understands that the COVID situation is a rapidly evolving situation, and we encourage you to check your health department and CDC regularly for guidance. Our event here today is not meant to take the place of medical advice, diagnosis, or treatment. Instead, we're here to give you information, resources that are important for you as a trusted resource. So please make sure to enjoy the program. With that said, I would now like to hand it over to Dr. Joshi. Dr. Joshi is an associate professor of pediatrics and medicine at the Mayo Clinic in Rochester, Minnesota. She is board certified in pediatric infectious diseases and allergy and immunology. Dr. Joshi sees adults and children diagnosed with primary immunodeficiencies and is involved in research at the Cellular and Molecular Immunology Laboratory, both at the Mayo Clinic and at the University of Minnesota. Please welcome Dr. Joshi. We are so excited to have you here.
Thank you very much, Ashley. And thank you so much for this invitation. Are you guys hearing me okay? Should be a little louder, okay? Yeah, okay. I'm so excited. There are about 84 participants, and I never thought we could do it all virtually. So I'm very excited in this time of COVID that when Kathy sent me an email, usually I'm kind of looking through my calendars and trying to figure out if it'll work out in the fall. But when the question was COVID, I was like, yeah, I'll do it whenever you tell me to, because I'm not traveling and most evenings are always flexible. So I'm very grateful I have this opportunity. And I have taken on more of a COVID role than I ever thought I would in my life. So, you know, with my dual board certification in infectious disease and allergy immunology, I wasn't practicing much of infectious disease. I was focusing on immune deficiency. And when the COVID issue has happened, I've taken on the safety officer role for our department. So something that has become closer to my heart than I ever thought an infectious issue would. Otherwise, I thought immune deficiency always trumped my interest. So I go back to this quote, and I think Ashley initially kind of gave the disclaimer. We think of truth as something that is invariable, but add a new circumstance and we have a new truth. This is so true in this current COVID era when we are seeing what we thought was true yesterday. We have a brand new evidence the next day, and what we thought yesterday was true, the next day is proven to be false. So we are just keeping up with new information, and I would strongly urge our participants today that what I may be saying may be true as of today, but things may be evolving at a pace that even every night I have to skim through most of the journals to keep up with what I'm telling my patients, as well as a recommendation in the clinic. So I think to make it simplistic, I have broken this talk down into trying to understand what COVID is in terms of three major players: the host, that is us, you and me, the pathogen, which is COVID, and the third thing is the environment that we live in. And when the right circumstances happen with the host, with the pathogen, and with the environment, we get the disease. And so always coming back to this paradigm will really help us all understand why certain people are getting the disease, why others aren't. And is it a more of a host issue, is it a pathogen issue, or is it an environment issue? So let's start with the pathogen. The pathogen that is the underlying culprit for COVID is the SARS-CoV-2, which is the virus. And it is a coronavirus, and the name is derived from the virus having crown-like appearances. So on this figure, if you see the things marked out as S, which are the spike proteins, and it gives it a crown-like appearance. We'll come back to this figure later on as we talk a little bit about vaccines if we have time, but most of the vaccines are targeting some of the crown-like appearance proteins to see if people can mount an immune response against the COVID. So are all coronaviruses the same? And that is a question that comes up very often. So we are all exposed to different coronaviruses, which are also called the common cold viruses. And here is a list of different common cold viruses that you would normally encounter. But the ones that we are very worried about are the novel coronavirus, one which happened in 2013, which was called the SARS virus, or the severe acute respiratory syndrome virus. And the other one, which was in circulation still, and it is still in circulation, is called the MERS virus, which is the Middle East Respiratory Syndrome coronavirus. It started in 2012, and it is still circulating in the Middle East. We don't hear much about it because it is not as infectious as the first SARS virus and the current SARS-CoV-2 virus. So the third one, as I talked about, is the SARS-CoV-2. So where did it start? And I think there has been a huge controversy around, did it start in the wet markets in Wuhan, China? Did it ever start in a lab in China? So far, the evidence does show that it started off in the wet markets in Wuhan, China, and there was skipping of the virus from a bat into humans. And the next slide shows how the viruses end up hopping, skipping, and jumping, trying to say that on the left side are the coronaviruses that we commonly encounter as common cold. And on the right side are the three novel coronaviruses that we have seen. The SARS-CoV-2, the intermediate host was a civet. For the MERS, Middle Eastern respiratory intermediate host has been camel. For our current pandemic, people are unsure if there is an intermediate host or if the virus directly jumped from bat into humans. But there are some studies that are suggesting that maybe pangolins could have been an intermediate host, but so far we don't have much clarity about it. So the COVID timeline goes on to show how quickly things have escalated for us. The first case was reported out in China in early December. And as time went on, the virus was identified in early January. By January 16th, the first case out of China was reported. By January 30th, it was declared as a public health emergency of international concern. They kind of went short of calling it a pandemic at that point in time, which the WHO has received a lot of criticism for. We had our first death in February, and as of last week, the states have started reopening in the United States, which has caused increased anxiety in our immune deficiency community. So with our global society, things have disseminated at a pace that has been difficult to imagine. This goes on to show how people travel across the globe in a 24-hour time period. So things that originated from Wuhan, China, quickly spread on to provinces in Italy, which had a close correlation to Wuhan due to the leather trade. And so there was a huge outbreak in Italy into Spain, and now we have seen huge outbreaks in the United States, with more than 85,000 people dying. So we've talked a little bit about the virus. We kind of talked about where it came from. Let's now focus on the environment. So we now know the pathogen is the SARS-CoV-2. The environment and the transmission of the SARS-CoV-2 is largely person to person through secretions. So it's the respiratory droplets which are the primary source. The mucosal surface from the nose, the mouth, and eyes, the secretions are also important, but because the respiratory droplets travel a long distance, it is considered to be the major culprit for patients to infect others. People have also done studies on other samples, and the virus has also been found in stool samples, and the transmission continues even after the respiratory secretions are negative. But for the purpose of this talk, I will focus on how we can limit our exposures to respiratory droplets, which are considered to be the primary source of transmission. So one aspect that you may have heard in the press is R0 or R0, which is how likely is one person likely to transmit either one person or two people. So let's say there is one person who transmitted to another person only, 1:1, the R0 for that disease is 1. So on the left side shows the seasonal influenza or the common flu that we see in the fall and winter months. The R0 for influenza is about 1.3, trying to state that one person may infect between 1 and 2 people. Compare that to COVID, where the R0 is between 2 to 2.5. I think as we have more data, it has remained between 2 and 3, saying that one person is likely to infect anywhere between 2 and 3 people. And so the COVID is more likely to be infectious as compared to the seasonal influenza. The second thing shows the incubation time, saying how long does it take from the first exposure to develop symptoms. This is really important as the states go on to liberalize people's movement and stay-at-home orders. The influenza, the incubation period is 1 to 4 days. So that is very quick that you will start having symptoms after being exposed. Compare that to COVID, where the incubation time is up to 2 weeks. So you may have been exposed, you may be pre-symptomatic, and you may be at high risk for infecting others for up to 2 weeks. And that kind of makes our whole guidelines of how do we handle this pandemic difficult. The next slide goes on to compare hospitalization rate, showing that this is not the flu, saying that only 2% of people who get the influenza get hospitalized. But so far, we've seen a much higher rate of hospitalization in patients with COVID. And the case fatality rate, meaning how likely are you to die if you get COVID, is much higher as compared to influenza. So it's not the regular flu as many people may think. It has many more caveats that makes it a difficult disease to control, as well as it has a high risk of burdening the healthcare environment. And so what happens with COVID, and why don't we have very good understanding of the disease? And why are the clinical trials not really giving us clear answers in terms of treatment? And it's very important to understand that depending on when you find somebody at what stage of the disease, the manifestation and the treatments that are effective will vary. So if a person is in very early stage of infection, versus which is usually the viral response, where you'll have typical symptoms of viral infection with fever, flu-like symptoms, cough, cold, diarrhea, and the newer symptoms that they have discovered are more lack of smell and lack of taste. Versus as the disease progresses, you may develop a hyperinflammatory response, where an antiviral medication may not be as effective as compared to early stage, where an antiviral medication is likely to be more effective. And hence, because studies have been done without kind of classifying patients into where the disease state was, we have not been able to get very cohesive recommendations onto saying which medication does or doesn't work. And so what are the host factors that affect your outcomes? And this is predominantly data from China, some from Italy, and I may have some added slides from the bigger cohorts in New York City, that it seems to affect mostly older adults. So patients who have underlying diseases, especially diabetes, high blood pressure, and obesity, seem to be at higher risk for having more adverse outcomes. So as I mentioned, the initial reports out of Italy and China did show that chronic respiratory disease seemed to be a risk factor for adverse outcomes in COVID. But our data from New York City did not really say asthma was a risk factor. So this is still under evolution as we get more data out of bigger cohorts, not just out of New York City, but throughout the country. So the common symptoms that I talked about were fever, lack of appetite, fatigue, loss of smell. It goes on to have more difficult, more disseminated manifestations. There are children's described in New York City with multisystemic inflammatory response, looking similar to patients who have Kawasaki disease. There are patients who are presenting with symptoms of acute appendicitis. Their appendix looks normal and their COVID testing is coming back positive. So what we understood about COVID until a few days ago is very different than what we understand about it now. Initially, we thought that kids were less likely to be affected, but we're finding kids are presenting with slightly different manifestation than as compared to an adult, where they initially start off with flu-like symptoms. And so what are the complications that we can encounter with COVID? Patients can have very difficult outcomes with developing septic and septic shock. They can be ventilator dependent with acute respiratory distress syndrome, which is the hyperimmune stage. They can have kidney injury, and they may need ECMO, which is extracorporeal membrane oxygenation. And so far, we've seen about 1.4% of the patients with severe COVID dying. And so how do we handle this? We really have struggled so far with very little directions in terms of treatment. And so everyone was falling back on trying to say, what are the preventive strategies that are available to us that can help mitigate or contain this pandemic? And so all of us must have heard about this entity called flattening the curve. So the purple graph shows that if the pandemic happens without any intervention, we'll have a huge peak that will exhaust our healthcare system's ability to handle the patients. And so like what we were seeing in Italy, that they had to decide whom to save and whom not to save, which was a very difficult ethical decisions for healthcare providers. Knowing that, I think people started really trying to work on containment, and that was the stay-at-home orders and social distancing. So if you look at the lower graph, you can really slow the acceleration of cases by social distancing, and that's when the stay-at-home order came about. And so this allowed the healthcare environments to really kind of work to improve their surge capacity so that they could, so like many healthcare environments kind of shut down their outpatient practice and delegated most patients to work in the inpatient setting, took off all elective care so that we could really delegate our resources for the surge likely to come and have enough ventilators available for patients to support them through the critical phase. And so what happened to us in Minnesota? So we, as those graphs showed, that if we had the outbreak without any intervention, we would have really gone and exceeded our healthcare capacity. But the MCR shows the Mayo Clinic in Rochester, where I practice, and we really were at overcapacity, meaning we did not really see the surge. And in retrospect, you may think, oh, it may have been an overkill with our stay-at-home orders and social distancing. But this is also a sign of success, saying we have not seen the surge that we had anticipated. And all the modeling prediction model had suggested at this point in time, we would have at least hundreds of patients in the ICU and a few thousands of patients in the hospital. In comparison, we have less than a dozen patients in the ICU and fewer than 20 patients with COVID in our hospital setting in Minnesota. And so knowing that, how do I protect myself? And I really thought hard for this talk, that what messages do I give to my immune deficiency patients, that is there something in their domain that they can do to really help themselves. So on an individual level, I think we can work on certain aspects that have been universal, trying to see how do I really help fight infection. So stress, as we are all experiencing, is very different kind. There has been an added burden of economic stress for many of us, with so many of us losing our jobs or being furloughed. But working on stress reduction is a great tool. There are many online options available. One of our partners here at the clinic has created a stress reduction program that he has offered the whole program free of charge. So no cost to the participants. And I'm happy to share that link, Ashley, if you want, after we finish. I forgot to add it here, but that's another resiliency training program. If people have heard his name, Dr. Amit Sood, he works with the Resilient Option. So he has offered his services free of cost. But I think stress reduction is a major issue that we can all work on. Exercise, as we all know, is really critical to improve our physical health as well as mental health. Now, the outcomes in the patients who were hospitalized with COVID, the ones who had much longer stay in the hospital or longer intensive care unit stay, started off with slightly poor physical health. And so I think even if we cannot prevent who gets sick, I think our physical health would really govern how long we are in the ICU and how do we do on the floors and how do we do afterwards. Because many of the patients that I have seen recovering from COVID are like patients who get the infectious mononucleosis and have post-infectious fatigue for not only weeks, for months. And so trying to get into the best possible shape today may help us kind of tide this wave if it ever ends up hitting us. Hydration, as we all know, is really critical. Sleep, I think it's all underappreciated, but that has significant impact on how our immune system functions. So working on sleep hygiene, which all of us can work on because we're all such a connected society. I try and answer my emails even at 10 p.m., which I should not be, but I think that has become an urge that is hard to quit, especially when things have been so time sensitive. There has been a huge focus on micronutrients and vitamin D, and there are some studies coming out saying if you are vitamin D deficient, replacing it and keeping the vitamin D more than 30 seems to help improve how your immune system functions. So if you remember the graph that I showed you, you go into an viral infection phase to an hyperimmune phase. The lack of vitamin D seems to tip you over to an overreactive response. Whereas if you have adequate amount of vitamin D, you seem to be more in an equilibrium phase, that you don't go into that overdrive. The studies are not very conclusive, hence there isn't a strong recommendation. But my point is, if you are low, and if you know if you're low in vitamin D, it may be a worthwhile exercise to replace it and keep it between 30 to 50 is the ideal ballpark estimate for vitamin D levels. I think that again is a question. The Institute of Medicine sometimes say 20 is also okay, but from an infectious disease prevention perspective, vitamin D levels above 30 are recommended. Another issue is optimal weight. Most of the patients that have had adverse outcomes with COVID, as I mentioned, have diabetes, high blood pressure. Both of these are kind of difficult for us to control and have been obese. So working on our weight, I know it's been a challenge for all of us, but I think it's just working to try and get as much possible closer to our optimal weight is ideal. So now these are all the things as a host you could do. What could you do for your environment? And this has been the major focus with our all state departments as well as from the federal government. And quarantine and social distancing has been the norm, trying to decrease the spread of the respiratory droplets. There has been a huge focus on hand hygiene, masking, and more recently, eye protection. And I'll show you a few slides what we are doing at our clinic here. And so I know that we may not have too much control over the virus, right? We yet do not have a vaccine. We don't have very good treatment strategies. So potentially working on the environment, which is a kind of a low-hanging fruit. We can easily social distance. We can work on hand hygiene, masking, eye protection. The host factors are always a work in progress because, you know, all of us, it's easy to say, but harder to implement, but something that we have to be more conscientious about our hydration, our sleep, our exercise, and that will ultimately lead to lesser stress and optimal weight. So as I mentioned, the vaccine is still on the horizon. There have been early studies coming out of the group that is making an RNA-based vaccine that they enrolled about 10 people and they had some positive results. So there is hope, and the hope is that we may have a vaccine available as early as January. I don't know for sure if it would be, but it would be sometime in 2021 that we should have a vaccine, because there are more than 100 different companies across the globe trying to work on the vaccine questions. Again, there is hope that most coronaviruses go through cycles. So there is some hope that the peak may die out over the summer months and there may be another outbreak in the fall. And people are a little worried about that second peak in the fall, because at that point in time, the influenza virus also will be in circulation. And so not only we shall be fighting COVID, but we may have to figure out how do we handle the issue around influenza. And so the question in our clinic setting was, how do we protect the patients and how do we protect the provider? So as we saw that there wasn't a surge in Minnesota, the healthcare systems were losing money. We had to furlough about 30% of our staff because the institution was relying on elective procedures, which we had all come to a grinding halt. Our clinic reopened their doors about 3 weeks ago. And the biggest focus beyond getting the practice started was safety. And so the graphic here shows that if there are two people in close contact, and the close contact is usually 6 feet distance, you have very high risk of transmission if neither one of them is masked. Now, if you think of another close contact where only one person is masked, the risk of transmission is lower. But the ideal environment would be when both the people are masked. In our clinic, not only as providers we are asked to mask, but we are also asked to have eyewear, protective eyewear, because as I mentioned, it is your secretions from your nose, your mouth, and your eyes that potentially can transmit the virus. So we are trying to protect ourselves from potential patients who may be asymptomatic, as well as us not transmitting the infections to the patient. So trying our best to keep our environment very safe. And so we also have tried social distancing, because in a hospital environment, it is difficult as patients try, and it's difficult to have that 6 feet. So our elevators are marked for social distancing. As you see, here are only 5 or 6 people are allowed to travel in an elevator. In the past, there used to be 15 or 20 people taking the elevator in one go. We are also tried to mark areas where patients should not be checking in close to the desk staff to keep at least 6 foot of distance. And we are asking patients to sit away from the providers to keep some distance. Otherwise, an exam room becomes a very close environment, and we are limiting visitors to only one person with the patient so that we are not crowding our environment in the hospital setting. And so what symptoms would trigger a visit, or what symptoms, if you would have, would mean that you need to get attention for COVID? So any new fever, a new cough, a new shortness of breath, a new sore throat. I know many of our immune deficiency patients do have symptoms of chronic cough or chronic shortness of breath, and that should not trigger a concern for COVID, but any new symptoms should. New chills, new muscle ache, and new loss of taste or loss of smell. Now, testing for COVID is becoming more common. In the past, there was difficulty in getting testing done, but now we are also testing patients if they have exposure to somebody in their family or a close contact who was COVID positive, in addition to having any of these symptoms. And so there are different tests, as you must have seen in the media. And there is a PCR test that detects the virus, and there is an antibody test that looks at immune response against the virus. So for many of our patients who have an immune deficiency, their ability to make antibodies is limited, not zero, but limited based on what kind of immune deficiency you have. So doing the antibody testing at times for our immune deficiency patients may be futile, and so we may have to rely more on the PCR test. The gold standard is a nasopharyngeal swab. Based on the healthcare system you are with, at Mayo, we get the results within 16 to 24 hours. Many places, it may take up to 96 hours. But the PCR test seems to have a very high sensitivity and specificity. The tests we have at Mayo, our sensitivity is more than 85%, but no test is perfect. So depending on when the swab was taken and how good the swab was, the person doing the swab testing can affect the sensitivity of the test. You may have seen other results from companies like Abbott. They have a quick PCR test within minutes. You may have a result back, but those are plagued with very high false negative results. So they're currently not recommended, even in areas where they have much higher rates than Minnesota. So we at Mayo are doing both the antibody test and the nasopharyngeal swab for asymptomatic patients, meaning if you're somebody who's going for a procedure unrelated to COVID, we want to ensure that you're not currently in the asymptomatic phase, and the antibody will help us also figure that out if we were previously infected. But if you come with acute infection, we are only doing the PCR test. And so I think kind of stress that, in the past, if you had flu-like symptoms, you could just go to the urgent care. Testing for COVID is more complicated. There are designated areas which will test you for COVID, primarily because the people testing you have to be wearing the right kind of equipment. They have to be wearing the personal protective equipment, what we call PPE, to test you. And so there are designated testing area. Like if you come to our clinic, you will not get tested within the clinic, but we have drive-through areas that you can go and get tested if you have consistent symptoms or have been exposed to somebody who could have COVID. And so this slide, I just kind of went on to stress, what about our immune deficiency patients? Because that has been the focus. And the fact that I have not had too many slides about immune deficiency and COVID is because there is not much reported. So if you look at the risk factors as in the epidemiology category 1, older age is a risk factor. If you have underlying lung disease, as the reports out of Italy and China, if you have chronic lung disease, it's a risk factor. Diabetes with hemoglobin A1C greater than 7.6, disease of high blood pressure or heart disease. Now the lower 3 goes on to show that if you have immune deficiency with low T cells, if you are a transplant patient or on chronic long-term steroids, you have a theoretical risk of having more adverse outcomes. They're saying it's not yet proven as a risk factor, but it is inferred from other infections. So we're just trying to play it safe, saying these patients don't do well with other infectious disease. So most likely they will have a more difficult time with COVID. Let's put them in a high risk category. But it has been a little bit of a surprise for me that most of our transplant patients and immune deficiency patients have so far escaped COVID. Is it just a question of time that they have been anyway very vigilant with hand hygiene and social distancing? Or is it truly something that these patients are on? And I'll talk a little bit about it in the next few slides that will help us understand. So what are the different treatments available? I think the only medication that has the FDA approval is remdesivir. So it's an antiviral medication that seems to work the best earlier in the disease phase as compared to later on, where there is this hyperimmune phase for which some immunomodulatory treatments seem to work better. This medicine is available for patients who are hospitalized and are not doing well. So let's imagine somebody who just has symptoms of flu-like symptoms and tested positive for COVID. At this point in time, there isn't one medication that is approved. There are various clinical trials that we'll talk about, but there isn't one FDA-approved medication for outpatient therapy for COVID. Hydroxychloroquine or chloroquine, as we may have heard a lot in the press, initially there were positive responses to this because this seems to have an antiviral effect as well as an immunomodulatory effect. But there hasn't been a clear consensus, and so we are using it. If you come to us, we will offer this or a few other medications as a clinical trial, meaning you will be randomized to this medication versus placebo to see really if this works or doesn't work. Hydroxychloroquine is also tried for healthcare workers on a weekly basis as a preventive strategy. Again, this is a clinical trial out of University of Minnesota, available for participation all over the country to see if we can protect the healthcare workers with once a week dosing, just like they do it for prophylaxis for malaria if you're traveling to a tropical country. So what can we do? I think I cannot stress this enough that it's really, really important that we wash our hands. Hand hygiene is critical. That masking is really important. Touching is very, very critical, that we really try and see knobs, doorknobs, places that are kind of used often. We really try hard to be aware of that and wash our hands. Keeping safe distance. So far, I think the fact that we have not seen a huge peak is the sign of the success of our social distancing measures. And staying at home as much as possible, and then seeking help whenever we can. And so I think I would like to leave you with a little thought as, we don't have one medication that works. I think it is going to be a multi-interventional cocktail until we have a vaccine available. And so the things that I stressed was hand hygiene, social distancing, screening, right? Knowing when you have fever, you yourself go through the checklist, masking and eye protection. And the most important thing is a cultural shift. It is one thing to know what we should be doing, but it is another to do it rigorously and thoroughly. I think many times I will see my coworkers, their mask has gone below their nose, and to call them out, many times you feel you are antagonizing a relationship that you shouldn't be on. Is it my job to call out on things? And I think we are in this environment that if I am not safe, I'm unlikely to keep you safe. And so I think we need to develop norms on how to address lapses in rules so that we can all comfortably call each other out whenever we see a standard slipping and still enjoy working with each other. So even in a store, when you go and see that people are not masked, how do we handle this as all the economy gets opened up, and how do we keep ourselves and our families safe? So I think it has to be a cultural shift in how do we address, because COVID is not going anywhere. And we may be dealing with small outbreaks over next 18 to 24 months. That's a prediction. And so we may have to find strategies, and ultimately a cultural shift will really bring this about. That's all I have. I know I was given a strict timeline, Ashley, so I hope I was within my timeline to help answer questions.
Thank you so much, Dr. Joshi. All of that information was so wonderful. I'm sure our audience is happy. As a reminder to everyone, please keep your questions coming. I have received quite a few. We're doing our best to keep up, but please do keep them coming. At this time, I would like to invite a word from our sponsors, Sid Fudke from Accredo.
Yeah, and hello everyone, hello from Accredo. Thanks to the IDF for hosting this and having us here. It's an amazing virtual event. This is my second one. And I think the information being shared and the interaction has just been wonderful. So we're truly honored and proud to be part of this community and to serve the community. And we look forward to, continuing to serve the community. Credo, a little bit about us. We are part of Express Scripts and Cigna. So we do have kind of a parent company and a grandparent company, but we, for the most part, operate independently. And so most of you probably just know us as a Credo. And, we do have a little more information. We hope to be able to discuss that with you in a little bit of a Q&A later in the breakout. So looking forward to that. Thanks, Ashley.
Thank you so much, Sid. We appreciate that information. Next, I would like to invite Dakota Fisher-Vance from Horizon.
Sure. Hi, everybody. I am on the patient advocacy team at Horizon Therapeutics and just really thrilled to get to be here and get to see how adaptive and willing the primary immune deficiency community is to continue to show up for each other during this really tough time. I know as zebras, you guys may not be unfamiliar with medical emergencies and having to stay home and miss out on events sometimes, but that doesn't mean it's not hard to feel isolated right now. However, IDF continues to show us through amazing events like this and their amazing communication that when you're part of the primary immune deficiency community, you're never really alone. So thank you to IDF for organizing tonight's event, and thank you to the incredible speaker for all of that great information. I know I learned a lot, and most importantly, thank you to you for showing up for your community even during this really tough time. Looking forward to connecting more at the exhibit hall.
Thank you so much, Dakota. We appreciate that. Let's go ahead and get on to our questions. So our first question from the audience: if two families, each with kids, both isolate for 2 weeks, can we socialize during this time?
So the question is, two families, each with kids, both isolate for 2 weeks, right? So is it because they're isolating due to exposure? So somebody was exposed, and I think my short answer is no. So you should socialize with people who live in the same household. Now, as the pandemic has gone on, it has been a little difficult. Who do you call your family or extended family? People are not able to see their grandparents, or people are not able to socialize with their grandkids. But I think the risk will still be because the exposures may have been different. You're isolating for 2 weeks because you have been exposed to an A person, and they may be exposed to a B person. And so I think the risk is high. I would suggest that it's better not to, as long as those 2 weeks pass, and then you can go back to your normal norms.
Thank you. Our next question: even though I'm isolated at home, do I still need to be vigilant about hand washing and sanitizing my house?
I think so, yes, because, I think we are not only dealing with COVID, we are dealing with many other infectious issues. So, and co-infection with a bacteria and COVID, especially staph, is increasingly being recognized. And so I think just good hand hygiene, part of this has to become part of your DNA, that even though I think we may already be doing it as an immune deficiency community, it is more important than ever to continue to do that.
Thank you. Our next question: I'm wondering how the efficacy of transmission via a contaminated surface compares to the efficacy of transmission via aerosol droplets. Are contaminated surfaces really that dangerous?
So that's a very good question. And I think the only study we have is the Princess cruise, if you remember, that was docked out of California. And they went on to look at surfaces even 14 days after the ship had embarked, and they could still find the virus. So it's unclear why it stays on surfaces for that long. So I think we have to work on both the surfaces as well as the aerosolized droplets.
Thank you. And our next question: I have CVID and GLILD. What options do I have if I end up contracting COVID-19? Do these two conditions severely threaten my chances for recovery from COVID-19?
That's a good question, and I don't know if your GLILD is also being treated. So something I did not go into detail during my presentation because we do not have much data is that so if you think there are very few patients with lupus coming down with COVID. In our institution, we have seen very few transplant patients coming down with COVID that needs hospitalization. And it's still early times, we don't really understand it well, but maybe some of the immunomodulators that patients are on seems to prevent the progression of the hyperimmune phase. And so if many of my GLID patients are also on Plaquenil, not because of COVID, but because of trying to work on their GLID issue. Is that protecting them? It's still early times, I cannot say for sure. Many of the GLID patients are on some other immunosuppression like azathioprine, or some of them have been treated with rituximab. So they may have some immunomodulatory role. Rituximab less so because it's a one-time shot, but if you're on Cellcept or azathioprine, that may have some role. So I think I wouldn't just your presence of GLID may or may not put you at risk. Sometimes the treatments for GLID may decrease your risk from going into that hyperimmune phase. And so I wouldn't really worry about your recovery. I would like to add something that we are trying to study here in our patients is, I have worried and I have had sleepless nights as the COVID epidemic started, thinking what is going to happen to our patients and that we don't have a very clear treatment. And I have been surprised in the last 6 weeks that I haven't had as many patients with immune deficiency showing up in the hospital or even sending me messages, even if they were not local, saying we've been sick and what do we do? And so a question came about that what is happening to I think Kathy initially was asking John about the hyperimmune globulin. And we are wondering, could IVIG be protective? Because there are some groups in Italy that have treated patients with COVID with IVIG. And so that is still considered experimental, but IVIG seems to have some beneficial effect more as an immunomodulator rather than treatment per se. But we have taken a few of our lots of immunoglobulin, both IV and sub-Q, and because we have an in-house antibody test for COVID, we are trying to test and see, are there COVID antibodies in which, if you really think of the timeline of the epidemic, it's unlikely that there would be any, but I think it's just good to know. And could there be cross-reacting coronaviruses? The initial slides that I showed of the common cold viruses, could there be any protection there? And if that's the case, why our immune deficiency patients seem to have done okay so far? Maybe they're all sitting at home and not being exposed, but we should have that answer for the immunoglobulin and the COVID antibody, if any, in the next 2 weeks.
Thank you. At this time, I would like to invite our audience member to ask their question. Joan, can you please ask your question to Dr. Joshi?
Sure. As places of employment, like schools, universities also reopen, should individuals with PI consult with their immunologist regarding additional precautions that might be needed?
Absolutely, Joan. So I think it would be very critical to come up with really a plan of kind of going back to work, whether they could work remotely, if they're going to be face-to-face, how many hours per week. So I think working with your immunologist to really get a plan. So I have done kind of work accommodation for many of my PI patients here at the clinic because I do think, our environment, we're trying to make it safe, but it is not foolproof. And so really working with your immunologist will really come up, and so that they could keep on reassessing as the pandemic evolves, whether things need to change over time.
Thank you. I would now like to invite Shannon to ask Dr. Joshi her question. Shannon, can you ask your question, please?
Yes, I'm wondering if it's going to be safe to swim in a pool, a lake, river, ocean, anything like that this summer.
So I would go back to what you did. So I think it's going to be partly the answer to that would be based on social distancing. So if you can, how we've seen pictures of how people crowding to the beaches in Florida and California, I think the bigger risk is the person next to you than the pool or the lake by themselves. What I've heard in Minnesota is that most public pools will be closed this summer. And so that may not be an option. And I think, I always worry about swimming in the lake with other infectious issues beyond COVID. So based on, I have some patients who have T-cell immune deficiency that I really restrict that lake swimming exposure. But I would base this decision more on social distancing that may be governing whether you could or could not swim.
Thank you, Shannon. Thank you, Dr. Joshi. I would now like to invite Grace. Grace, can you please ask your questions, Dr. Joshi?
Sure. Will cleaning things like my mask and cell phone with a UV light kill the virus?
Hello, Grace. Good to see you. It's kind of, there are enough reports around that people have tried to reuse their masks and use UV light. I think the problem there is we're not 100% sure what distance the UV light has to be and how long. And so I think if you're using it, that is fine, but I wouldn't 100% rely on it. And so we as healthcare providers have been asked not to do that.
Thank you, Grace. Our next audience member, Sarah. Sarah, can you please share your question with Dr. Joshi?
Yes. Why do we keep hearing that a second wave of COVID-19 is going to be worse than what we're in right now?
I think the second wave, so I think they're going back to the pandemic, the flu pandemic of 1918, right? Where the initial wave wasn't that great. People were like, we know it's nothing. And then people really relaxed on the hand hygiene, the screening, the social distancing norm. And there was a much bigger peak later from 1917 into 1918. So I think that history goes to kind of more of a cautionary tale for us. And the second thing I think I mentioned earlier was the likely contribution of seasonal influenza in the fall. And so I think the combination of COVID with influenza will really kind of exhaust the healthcare capacity, and that's why everyone is so worried about it. And so even to kind of liberalize the norms, people have been little wary, saying even in the fall, many schools are not restarting, and they're working on distant learning measures.
Thank you. Our next question, should we be wearing masks on neighborhood walks?
It's a good question, and I don't think for neighborhood walks you should be wearing mask as long as you can have the 6-foot distance. So if it's a very crowded park, I would suggest not going for walks. But if it's in your neighborhood, which is not like the inner city areas of any big city, it should be okay to go without masks.
Everyone, you're sending a lot of questions. This is so wonderful. I'm having a hard time keeping up with some of them, so we're not going to have them come out on the slides, but I am going to read some of the questions that we have in. Dr. Joshi, from one of our audience members, if schools open in the fall, will immunologists provide guidance to parents or children with PI?
Oh, absolutely. I think we'll really have to look very closely on who can go back to school based on what kind of learning environment and distancing they can have in the classrooms.
Thank you. Should children with PI utilize distance learning longer?
Potentially, but again, I think we haven't really seen a huge peak in patients with PI. I think the next few weeks, as more data comes out of CDC, we'll have a better understanding. But so far, it looks like that PI is a high-risk category, that distance learning may be something to consider.
Wonderful. Our next question from the audience, will it become mandatory for medical professionals to be tested before they see patients?
This is such a good question, Ashley. So we had been begging our leadership, asking for us to be tested, saying, we worry about the patient coming in who is in the asymptomatic or the pre-symptomatic stage. How can I be sure I'm not in that state? And so far, most healthcare institutions were not having enough testing abilities or capacity. So we were at about 5,000 tests per day. And now we've really ramped up to about 7,000 to 8,000 tests per day. So it is coming. Next month onwards, we are offering the antibody testing to all our employees. And then if your antibody is positive, you can go ahead and get the PCR testing done. All of this is voluntary. It's not mandatory, but just the same question where a patient asked me, how could I be sure you are not infectious to me, just the way I worry that the patient is not infectious to the healthcare provider.
Thank you. Another question from our audience member. Will staying in quarantine reduce your immune system health?
So that has been, I think there has been a counter movement to this, saying that, you know, you need to be exposed to certain viruses and bacteria. I think at the current critical juncture where so much is unknown, I would not worry about the immune system not being kept active, if you were to say that, by staying in quarantine. I think going out for walks and keeping active is good. You know, you don't have to stick in your 20 by 20 bedroom, square footage bedroom, I think. But quarantine at this stage until we have more clarity is critical. You know, the people in Italy have died not because of COVID only, but because there were not enough ventilators available. So it's a disease where if you have enough capacity for the healthcare environment to offer ventilators to people who need it, you will most likely survive. And so I think with PI, our risk for other issues are anyway high. So until we have more clarity, I would suggest that quarantine should not really weaken your immune system.
Perfect, thank you. Our next question. When a COVID-19 vaccine is available, with CVID, I am concerned about taking it. Is it likely CVID will impact one's ability to take the vaccine?
Yeah, so, you know, there are two things with the vaccine, whether the vaccine is safe and whether the vaccine is effective. So I think most of the vaccines, you know, how we worry about live vaccines, that they may not be safe in many of our immune deficiency patients based on where their T cell numbers are. So most of our CVID patients who are on infusions only get the killed influenza vaccine. So once the vaccine is out, and knowing what kind of vaccine, is it a live vaccine, or is it a subunit vaccine, or is it a protein conjugate vaccine, we can potentially consider that as an option. I wouldn't completely dismiss the presence of CVID against vaccination, because as long as the vaccine is safe, the next question is the effectiveness. And that we can figure out as time goes based on responses in the other bigger cohorts of patients. So I would be open to considering what vaccine can potentially be given once they are out in the market.
Thank you. Another question from our audience. What is the difference between swab testing and nasal swab testing in terms of accuracy of diagnosis?
Yeah, so the nasopharyngeal swab, where the swab goes all the way at the back of your nose, I have myself gone through that testing for one of my own procedures, and I found it to be extremely uncomfortable, is much more sensitive. So most places will not accept a throat swab. It has much poor sensitivity. So the virus particles are less likely to be picked through a throat swab as compared to a nasopharyngeal swab. Now, if you've had some nose issues, like if you get nosebleeds or if you had a nose surgery that the swab cannot be pushed into your nose, then a throat swab is okay, not ideal, but okay.
Another question from our audience. I don't run a fever when I get sick. Will I be able to receive testing for COVID-19 if I think I am sick?
So if you may need other symptoms, so presence of fever alone is not a mandatory requirement. So as long as you have a new cough, new sore throat, new diarrhea, new loss of smell, new loss of taste, you would be a candidate to get testing done.
A very important question that I think a lot of us have had on our minds. When hair salons and nail salons start to open, should we wear face coverage? A lot of our audience, I'm sure, is ready to get a haircut.
Absolutely. So June 1st, I know I have kept it on my calendar. So June 1st is our deadline where the hair and nail salons, absolutely, you need a mask, and you have to insist that your hairdresser also wears a mask, and that they're trying to keep some social distancing so they're not crowding the place. And most of the places are coming out with saying they're starting out at 25-30% capacity to start out so that they can keep the social distancing in.
Thank you. And this will be our last question. Does IG therapy protect me from COVID-19? When will it have antibodies against COVID-19?
Good question. So I, as I mentioned, this had been lingering in my mind, and I don't want to get anyone's hopes up, but there may be some positivity in our current infusions, even though, as I think John initially mentioned, because the lots are at least 9 months, and the patients who have donated could be somewhere between 6 and 9 months. So any product that you're getting today could be as old as a year to 15 months before somebody had given their blood donation for the infusion. So the presence of COVID antibody per se is less likely. We don't think COVID was in circulation a year ago, but could there be some cross-reacting coronavirus antibody in it that may be offering some protection? I think we are doing 2 different kinds of assay in our clinic. We are doing a neutralizing antibody assay as well as the current IgG antibody assay, which is just the presence of the antibody. We don't know if that antibody is protective. So as I said, I will have answers in a couple of weeks' time.
Thank you so much, Dr. Joshi, for taking these questions, for being here. We truly appreciate your time. I would like to thank our audience members for sending them their questions. If your question was not answered today, please feel free to continue sending them. We will work to try to get answers to your questions at either our next meetings, on our blog post, but please continue to send them in. At this time, I would now like to invite Greg Logston from CSL Behring for a quick word from our sponsor.
Excellent. Thank you, Ashley. I appreciate that. And Dr. Joshi, thanks for your time and expertise. A lot of great questions out there. It's very fascinating and it's scary at the same time. But, and Dr. Joshi, I mean, that stress reduction program, you might have a candidate. I might need to join one of your programs coming up. This virtual world is quite stressful. But once again, my name is Greg Logston. I work with CSL Behring. If you're not familiar with CSL, we manufacture 2 IG products, one Privigen 10% IVIG, Hizentra the 20% sub-Q. And I mean, these IDF events, be it a walk or just an in-person meeting or event, IDF event, is definitely one of my favorite parts of the job. I mean, it's a great time to interact, great time for everything to be put in perspective and get to hear what's going through your minds, what's working, what's not. It's a great part of my job that I do get to take advantage of, and I just wanted to thank all of you for that, and IDF as well, inviting us to this event. Really do appreciate that. So everyone, I hope everyone's safe. Looking forward to the breakout room, and thanks again.
Thank you so much, Greg. We appreciate your time and your words. With that, I would like to hand it over to John again to lead us into the breakout room.
Great. Well, thanks, Ashley, and thank you, everyone, for sticking with us into the evening here. Dr. Joshi, thank you so much. That was phenomenal. I saw a couple of slides that you had that I'm hoping that we'll get up onto IDF social media at some point. And I've got to say, the true test of this was my 10-year-old was kind of hovering around, and a couple of times you were saying something, you saying, really? So it is information that is well received, and we do appreciate it. And you know, this is so needed, so timely. So thank you so much, Dr. Joshi, once again for answering the call and for providing us with information that is so very much needed. Now, we've had a couple of commercials from others, and so I want to do a quick little plug for IDF. You know, once this meeting is over, the fun, the learning, everything does not have to stop. And so I really hope, as I mentioned earlier, that you'll visit our website, you know, for all of the information that is on there, and especially for the newer folks to our community, the Patient and Family Handbook, which debuted earlier this year, the newest edition with the the most up-to-date information, just came out, and it is a great resource. But also we've got resources for different age groups, some diagnosis-specific information, and just a wealth of things that will help us to stay in contact and hopefully to give information. If you're not feeling so much like the visual learner today, there's a lot of things to read and to share with your friends, your family, your herd, and maybe even some of your medical professional partners. So with all of that said, and my commercial for that part, I did want to mention that the support options that we have beyond the little bit of chatting that a few people and I have been doing here are open. We really do need to stay in communication. The isolation is trying, and so we have a whole host of different ways of staying in contact with one another and answering questions that only fellow zebras, oftentimes really can do. So I hope that you will check those out and let us know how it is that we can help. So I believe that if you have any questions after all of this, which is possible, this good information generates more questions, you will get in contact with us at primaryimmune.org/askidf. We are used to all sorts of interesting questions. We have answers, or can refer you to a lot of great resources for some of them. But we will. If it's a new one to us, we will do all that we can. And I did just get a question asking about particular support groups for children of a certain age. And we are rolling out more and more of those over the next couple of months because, again, everyone is being distanced. But frankly, as we are getting used to Zoom and the different technologies, and also I would say the privacy issues that are in, expect to see something coming in the not too distant future, but not just yet. But there will be more and more of them as we go. So with all that, let me say one more final thank you to the sponsors. Again, you'll be meeting with a few of them in just a minute here. Thank you everyone for being a part of this. We are holding these events almost every week. It kind of depends a little bit, on what's going on. But we're, again, trying to make sure everyone stays up to date with COVID, plus adding in, again, some other information as it comes up, in part based on the poll that you filled out earlier, telling us what it is that you are interested in. So just really appreciate the fact that you have stayed to learn. We will stop with the recording momentarily, and we can just chat for those who are not going to rush right off. But thank you all, and all of us at IDF. I hope that you stay healthy, safe, sane. I think that's important these days, and just have enjoyed having you with us. We're going to have plenty more of these. There's going to be a lot of more ways that you'll be able to get involved as we go from transitioning to virtual to doing all sorts of new things to hit you all where you live at your computers. So just keep those cameras and microphones handy. There's going to be a lot of ways for us to interact, even as we practice good social distancing, as Dr. Joshi said. So thank you all. And for those who need to leave, good night, good luck. And for the rest of us, just hang out for a few minutes as we unwind. Take care.